As future healthcare professionals, you stand at the forefront of change, ready to dismantle barriers, challenge stigma, and deliver compassionate care to those affected by HIV. The next few moments, we will delve into a systematic approach to HIV diagnosis and management. So, what is HIV? HIV is a retrovirus that infects CD4 lymphocytes. The reduction of CD4 T helper cells decreases cell mediated immunity and therefore increases a patient's risk of opportunistic infection. It is a blood-borne virus transmitted via sexual intercourse, shared intravenous drug, and vertical transmission. HIV disease is caused by HIV-1 or HIV-2 infection, which are retroviruses in the Retroviridae family, lentivirus genus. What is the difference in HIV-1 and HIV-2? HIV-1 infection is the most common species worldwide and is primarily seen in the US. HIV-2 infection is primarily in West Africa. Highly active retroviral therapy has the capability to suppress HIV to undetectable levels. As a result, persons living with HIV can live a long and healthy lives, and the virus becomes non-transmittable through sexual contact. The rallying cry, quote, undetectable equals untransmittable, abbreviated as U equals U, was coined in 2016 by the Prevention Access Campaign in the United States. The slogan aims to heighten awareness that when HIV is undetectable, it is no longer transmissible through sexual means. Now let's discuss the stages of HIV infection. HIV infection can be divided into the following stages: viral transmission, acute HIV infection, and chronic HIV infection. Chronic HIV infection can be further subdivided into the following stages: chronic infection without AIDS, and AIDS, which is characterized by a CD4 count of less than 200 or the presence of any AIDS-defining conditions. As for the viral transmission, keep in mind that HIV infection is commonly contracted through sexual intercourse, exposure to infected blood, or perinatal transmission. As for the second stage of HIV infection, it's called acute HIV infection or acute retroviral syndrome, also known as ARS. It refers to a group of symptoms that can occur when a person is initially infected with HIV. This phase of infection typically occurs within the first few weeks after exposure to the virus. The symptoms of acute retroviral syndrome can resemble those of other viral illnesses and may include fever, often accompanied by other flu-like symptoms, profound fatigue, which is a common symptom during this phase. Some people may experience muscle aches and pain in the joints. Sore throat can be one of the early symptoms of ARS. There are enlarged lymph nodes, particularly in the neck, armpit, or groin. Patient may present with persistent or severe headaches. Patient may also have a rash that's often red and itchy. It's important to note that not everyone who becomes infected with HIV will experience these symptoms, and some people may not have any noticeable symptoms during the acute phase. Additionally, the symptoms of ARS can be mistaken for other viral infections, contributing to challenges in early diagnosis of HIV. As a result, the diagnosis of HIV is frequently overlooked. The incubation period is usually 2 weeks to 4 weeks, and during the symptomatic phase of the acute infection, HIV antibodies may not be detectable until 14 days after exposure. As for the third HIV stage, it's called chronic infection without AIDS. These individuals with HIV may be asymptomatic, though some might experience generalized lymphadenopathy or nonspecific symptoms. Additionally, Specific HIV associated clinical manifestations, such as oral thrush, seborrheic dermatitis, and infections with herpes, HPV, bacterial pneumonia, and tuberculosis, may manifest even when the CD4 count is greater than 200. As the CD4 count approaches 200, these conditions tend to become more frequent and often more severe and even fatal. And the last stage of HIV is called AIDS. This is characterized by a CD4 count of less than 200, or the presence of any AIDS-defining condition, regardless of the CD4 cell count. AIDS-defining conditions encompass opportunistic illnesses or even malignancies that can occur more frequently or severely in those who are immunocompromised. These primarily involve opportunistic infections that are high yield on your exam, such as PCP, toxoplasmosis, and disseminated Mycobacterium avium complex infection. Certain malignancies like Kaposi sarcoma and lymphoma, along with conditions lacking a clear alternative etiology but believed to be linked to uncontrolled HIV infection itself, such as wasting or HIV encephalopathy. These are all classified as AIDS-defining conditions. The U.S. Preventative Services Task Force, USPSTF, recommends that HIV screening should be performed in all adults and adolescents at increased risk for HIV infection, as well as pregnant patients. This slide is very high yield and is one of the most common questions asked on your board exams, so please listen. Serological assays are used for screening and diagnosing HIV. Fourth generation HIV test can detect both HIV antigen and anti-HIV antibodies, but it cannot differentiate between HIV-1 and HIV-2 infection. These serological assays are detectable around 14 days after HIV exposure. HIV-1 and HIV-2 antibody differentiation immunoassay are lab-based tests that can differentiate between HIV-1 and HIV-2. It is the lab test ordered in the US to confirm the diagnosis of HIV. Unlike the fourth generation test, the antibody differentiation immunoassay is detectable in about 3 weeks after HIV exposure. The first step to order is a fourth generation HIV test. If there is a positive result on a combination assay, order an HIV-1 and HIV-2 antibody differentiation immunoassay. If the HIV antibody is positive for HIV-1 or HIV-2, then the HIV infection is confirmed. However, if the fourth generation combination assay is positive, but the HIV antibody differentiation immunoassay is negative, then the next test to order is an HIV RNA binucleic acid amplification testing. And if this is positive, acute HIV infection is confirmed. Before we talk about HIV management, let's first talk about the importance of pre-exposure prophylaxis. Pre-exposure prophylaxis, commonly known as PrEP, involves the use of medication to prevent HIV infection. When taken as prescribed, PrEP proves highly effective in averting HIV transmission. It is a daily medication for patients who are at high risk for exposure to HIV. A two-drug regimen of tenofovir and emtricitabine is taken once daily. PrEP significantly diminishes the risk of acquiring HIV through sexual contact by approximately 99%. In cases of injection drug use, PrEP still offers a substantial protection, reducing the risk by at least 74%. It is crucial to note that the effectiveness of PrEP diminishes if not taken as prescribed. While PrEP provides robust defense against HIV, it does not shield against other sexually transmitted diseases, and therefore the use of condoms remains important for comprehensive protection. The patients who are at high risk of HIV infection includes the following: men who have sex with men, patients with multiple sexual partners, such as those in a polyamorous relationship, persons who inject drugs, persons who engage in transactional sex or who are trafficked for sex work, and transgender persons with multiple sexual partners. If the patient is already on PrEP and has a positive HIV test, a third agent is added, either a ritonavir boosted darunavir or dolutegravir. What about post-exposure prophylaxis for HIV? In post-exposure prophylaxis, the medication should be started as soon as possible and is not recommended if the exposure has been more than 72 hours. A three-drug regimen for 4 weeks is recommended, and the preferred regimen is tenofovir plus emtricitabine plus either a ratutrelvir or a dolutegravir. During a routine health maintenance visit, a 21-year-old male student consults his primary care doctor, expressing concern about minimizing his risk of HIV infection due to engaging in sexual activity with multiple male partners and inconsistent condom use. His medical history is unremarkable and he is not taking any medications. The physical examination reveals no abnormalities. Lab results indicate normal serum creatinine level, and tests for syphilis, gonorrhea, and chlamydia were all negative. Additionally, the HIV test returns negative. What is the most appropriate management? Encourage to use condom and avoid starting any antiretroviral medication. Initiate tenofovir and emtricitabine daily. Initiate tenofovir, emtricitabine, and dolutegravir. The right answer is tenofovir with emtricitabine. The combination of tenofovir along with emtricitabine, when taken once daily and adhered to consistently taking it every single day, has been shown to effectively reduce the patient's risk of HIV transmission of more than 90%. What is the primary treatment if the patient has both HIV and chronic hepatitis B? In this case, the patient should receive tenofovir plus emtricitabine or lamivudine-based regimen, which treats both HIV and hepatitis B. Now let's talk about another case. This is a 30-year-old male nurse being assessed following a needle stick injury in a clinic. The needle, used for intravenous therapy on a patient known to have HIV infection and taking antiretroviral therapy, had blood on it, but the patient's recent viral load is unknown. The nurse has already cleaned his wound. His medical history is unremarkable, and he takes no medications. Vital signs and physical examination findings are normal. What is the most appropriate immediate management? The recommended management in this case is a post-exposure prophylaxis regimen for HIV, and this consists of tenofovir, emtricitabine, and either dolutegravir or raltegravir. Sexually transmitted infections are common among individuals with HIV, and it is crucial to note that being on PrEP does not reduce the risk of contracting STIs. These infections can lead to significant morbidity, and some may not present with noticeable symptoms. It is recommended that patients with HIV undergo routine lab screening for syphilis, gonorrhea, and chlamydia. Moreover, those with HIV who engage in vaginal sex should also be tested for trichomonas. The most commonly used test for initial screening for syphilis is the non-treponemal test, which includes VDRL or RPR test. These tests detect antibodies that the body produces in response to a syphilis infection. If the non-treponemal test is positive, a confirmatory test called treponemal test is usually performed. Examples of treponemal tests include FTA-ABS test or fluorescent treponemal antibody absorption test. Initiating antibiotic prophylaxis for opportunistic infections depends on a CD4 cell count. It is important to check CD4 counts every 3 months to 6 months in a new HIV diagnosis, and then yearly monitoring is recommended in chronic HIV with undetectable viral loads. Prophylaxis against PCP is crucial due to its potential to cause severe infections. In individuals with CD4 counts below 200, prophylactic use of trimethoprim sulfamethoxazole, also known as Bactrim, has demonstrated efficacy in preventing PCP. When the CD4 count surpasses 200, Bactrim may be discontinued. In cases where Bactrim is contraindicated, alternative options include dapsone, atovaquone, or monthly nebulized pentamidine treatments. It is important to note that screening for GCPD deficiency is required before initiating dapsone. Bactrim also prevents toxoplasmosis and should be given when the CD4 count drops to below 100 if the patient is not already receiving it to prevent PCP. The patient is at high risk of Mycobacterium avium complex if the CD4 count drops to below 50. The recommended treatment is weekly azithromycin or clarithromycin. All individuals diagnosed with HIV should undergo tuberculosis screening using either PPD testing or interferon gamma testing such as quantiferon B, unless they have documented history of TB or have previously tested in a screening test. In cases where the screening test is positive, or for individuals who are close contacts of those with infectious TB, a chest x-ray is recommended to rule out active tuberculosis. Regardless of the screening test results, both groups should receive treatment for latent tuberculosis once active disease has been ruled out. Now let's talk about a case. This is a 30-year-old male with HIV who reports compliance with daily antiretroviral therapy. 3 months ago, his HIV quantitative RNA was undetectable and a CD4 cell count of 150. Because the CD4 cell count was less than 200, he was started on Bactrim. He comes in 3 months later for a follow-up. His HIV viral load remains undetectable and his CD4 count increased to 300. What is the most appropriate management? Continue Bactrim, start azithromycin, start isoniazid, or discontinue Bactrim. In this case, what's recommended is to discontinue Bactrim. This patient has an excellent response to antiretrovirals due to an undetectable viral load and a rising CD4 cell count. Since the CD4 cell count is above 200 for more than 3 months, Bactrim is no longer indicated as prophylaxis for PCP. Due to advancements in HIV management, patients are encountering fewer complications and enjoying extended survival. As a result, they are increasingly experiencing common health problems seen in the general population, and these problems must be addressed. The risk of cardiovascular disease is twice higher in patients with HIV, and therefore, HIV patients should be screened for hypertension, hyperlipidemia, and diabetes. Chronic kidney disease is a common condition, and checking kidney function every 6 months is recommended. Tenofovir is associated with tubular nephrotoxicity, which is usually associated with proteinuria. If the patient is on tenofovir, urinalysis or urine protein is recommended twice per year. Bone mineral density is reduced in patients with HIV, especially if the patients are taking tenofovir. DEXA is recommended in postmenopausal women, history of fragility fracture, long-term use of steroids, and men over 50 years old. In patients taking antiretroviral medications, this syndrome is associated with abnormal central fat accumulation and localized loss of fat tissue. The condition is called HIV-associated lipodystrophy. HIV lipodystrophy manifests as an abnormal accumulation of central fat or localized loss of fat tissue in patients on antiretroviral drug treatment. Egrifta is a growth hormone releasing factor, received approval from FDA in 2010 for the purpose of diminishing excess visceral abdominal fat in HIV infected patients experiencing lipodystrophy. Now let's talk about another case. Here is a 38-year-old male with advanced HIV infection with a CD4 cell count of 50 on HIV treatment. Despite adherence, the patient returns for follow-up complaining of a new worsening symptoms. On examination, there is evidence of swelling, redness, and tenderness over previously enlarged lymph nodes. The patient denies any recent infections or exposure to sick contacts. The lab results show an increased inflammatory response. What is the most likely explanation for these findings? And what term is commonly used to describe this phenomenon? The patient is likely experiencing immune reconstitution inflammatory syndrome, also called IRIS. In patients with HIV, the term IRIS describes an inflammatory response associated with a paradoxical worsening of a pre-existing infectious processes following the initiation of antiretroviral therapy. It occurs months after starting antiretroviral therapy in patients with a low pre-treatment CD4 cell count of less than 100. Now let's talk about HIV management. In general, the objective of treatment is to safeguard the immune system, preventing its deterioration to a level where the patient becomes highly susceptible to opportunistic infections, which can be potentially fatal. The goal is to start HIV treatment within 2 weeks of HIV diagnosis. Antiretroviral therapy, also called ART, is recommended in patients with HIV infection to reduce morbidity and mortality, as well as to reduce HIV transmission to others. HLA-B 5701 testing should be performed before initiating abacavir therapy. Patients who are positive for the HLA-B 5701 are at high risk for hypersensitivity reaction and should not be taking this medication. If the patient is on optimal therapy, HIV RNA should become undetectable. What about this 45-year-old male patient newly diagnosed with HIV infection is started on antiretroviral therapy consisting of abacavir, lamivudine, tenofovir, and boosted atazanavir. 2 weeks later, he presents with a rash, fever, and malaise. Laboratory test shows an elevated eosinophil count. What is the most likely cause of his symptoms, and what alternative ART regimen should be considered? Abacavir is associated with hypersensitivity reaction. It is characterized by rash, fever, and systemic symptoms. Discontinuation of abacavir and initiation of an alternative regimen is crucial in this case. Integrase inhibitor regimens are preferred due to low side effect and high potency. The recent recommendations include the following integrase-based regimens and therefore high yield on your exams. The first one is bictegravir, tenofovir, emtricitabine. Second one is dolutegravir, abacavir, imivadine. And third is dolutegravir plus tenofovir plus emtricitabine. Now, after starting ART regimen, order a CD4 count and HIV viral load at 6 weeks, 3 months, and 6 months, then every 6 months. Once treatment is initiated, ART is continued indefinitely. Now that we have started the patient on a HIV regimen, we also have to keep in mind resistance. The most common reason for an increase in HIV RNA viral load is poor medication compliance. If the patient is compliant, but the HIV viral load remains high, resistance testing can be used to guide selection of a new regimen. Drug resistance testing involves genotyping or phenotyping of resistance in the patient's viral strains. And what are the two types of resistance testing? It can be genotypic, which is identifying for mutations associated with drug resistance. This is faster and relatively inexpensive. It can be phenotypic, assessing if the virus can replicate and therefore useful in the presence of multiple mutations. The latest guidelines advocate for genotypic testing to inform the selection of initial therapy in antiretroviral naive patients, as well as in individuals for whom the first or second regimens result in a suboptimal virologic response or virologic failure. Now let's talk about rapid fire questions and answers that are high yield on your exam. Here's one case. A 29-year-old male presents to the clinic with flu-like symptoms, including fever, sore throat, and fatigue. He reports high-risk sexual behavior and requests an HIV test. Which test is the most appropriate for initial screening in this patient? HIV-1 RNA assay, ELISA, Western blot, or CD4 T cell count? The correct answer is HIV-1 RNA, since the patient is exhibiting a strong clinical suspicion of acute HIV infection. Which antiretroviral drugs are commonly included in post-exposure prophylaxis regimen? A 3-drug regimen for 4 weeks is recommended, and the preferred regimen includes tenofovir, emtricitabine, plus either raltegravir or dolutegravir. Which antiviral medication increases the patient's risk of chronic kidney disease and osteopenia? The right answer is tenofovir. A 32-year-old male patient with newly diagnosed of HIV infection presents with cough, fever, night sweats, and unintentional weight loss. Chest X-ray reveals bilateral infiltrates. Sputum smear and culture are positive for acid-fast bacilli. What is the most likely opportunistic infection in this patient? Is it pneumocystis, cryptococcal, Mycobacterium avium complex infection, or tuberculosis? The correct answer is tuberculosis. HIV positive individuals are at increased risk for tuberculosis, and the clinical presentation often includes pulmonary symptoms, night sweats, and weight loss. Positive acid-fast bacilli on sputum smear and culture supports this diagnosis. A 28-year-old male with advanced HIV presents with chronic diarrhea, abdominal pain, and weight loss. Biopsy from a colonoscopy shows foamy macrophages containing acid-fast bacilli. What is the most likely opportunistic infection in this patient? Is it crypto, CMV, isosporiasis, or a MAC infection? The correct answer is Mycobacterium avium complex infection. MAC is a common opportunistic infection in individuals with advanced HIV, especially if their CD4 count is below 50, and it can involve the GI tract causing chronic diarrhea, which is diarrhea of more than 1 month, as well as weight loss. 50-year-old male patient with long-standing HIV infection presents with shortness of breath, non-productive cough, and bilateral interstitial infiltrates on chest x-ray. CD4 T cell count is very low. A bronchoalveolar lavage reveals a cyst form of the organism. What is the most likely opportunistic infection in this patient? Toxo, PCP, Aspergillus, or histoplasmosis? The correct answer is PCP. PCP is a common opportunistic pathogen in individuals with advanced HIV infection with CD4 count of below 200, causing interstitial pneumonia with bilateral infiltrates seen on chest x-ray. The primary objectives of the initial assessment for an adult diagnosed with HIV includes the evaluation of the stage of the HIV disease, assessing the risk for additional infections, identifying comorbidities linked to HIV infection or pertinent to its treatment, and choosing the appropriate antiretroviral regimen. And so, in conclusion, HIV remains a complex and a dynamic global health challenge that necessitates ongoing research, awareness, and comprehensive healthcare strategies. While the advancements in antiretroviral therapies have significantly improved the quality of life for patients living with HIV, persistent efforts are crucial to enhance prevention and reduce stigma, and ultimately work towards a world free from burden of HIV and AIDS. Thank you and have a great day.